Hello, my name is Marc Raab and we are here in Edinburgh, Scotland at the Myeloma 2017 meeting. And I am joined by my colleague Jonathan Keats from TGen, Director of Bioinformatics there. And we are discussing a session that was held yesterday on Genomics 2016, What Have We Learned? So Jonathan, what is your main message on the newest releases of genomic data, mainly from the CoMMpass trial, of course, that you are heading?
I think we're continuing to find a lot of things that have been well established in the field. Probably what were, between a lot of the studies that were presented, that has really improved is we now have a solid understanding, I think, particularly of how tumors are evolving with time. I think a number of studies showed a lot of the features that we focus on are fairly stable with time, but for the most part, there was diversity with time, but then there sometimes wasn't. But in general, we see that a vast majority of the molecular features are constant with time that really highlight those things that are probably the most valuable to go after therapeutically. And the rest is a lot of noise that probably has value in particularly creating resistance to some of the drugs potentially and maybe create new mechanisms for targeting those patients. But I think we're starting to get a better feeling from a lot of these studies on what are the one or two things or 20 things that are very commonly present in a lot of patients, but also common in all the tumor cells that will be the best things to target in the future.
So you have looked at, I think, more than 900 genomic data or genomics from 900 patients who were enrolled in the CoMMpass trials at time of first diagnosis, of course. And so do you see any new subgroups coming up, so in terms of tumor heterogeneity from between different patients and clustering of certain genomic features that might form new subgroups of myeloma?
Compared to the classic, depending on the different studies, there's been studies showing there's 8 to 11 groups, and with our data, we've put a lot of effort into trying not to over-segment the data, but we do have a number of groups, like one we talked about yesterday, that we see both in the RNA data in our data set and the DNA data set. Is there's a group of patients who are clearly non-hyperdiploid, but do not, for the most part, have any of the translocations we typically would study in the disease. But it's a group of patients that have a lot of copy number losses that have individually historically been associated with poor prognosis. So that definitely seems like a novel subset that hasn't been well defined in the past, that we can replicate on both the RNA side and the DNA side, and it's actually the only group that we identify as individual subsets in the RNA and DNA side other than the classic translocation subsets. So I think there's something very novel there that we haven't talked about, but outside of that, what we've been doing is really subsetting a lot of the individual groups that were identified. So we break hyperdiploid into 5 different groups now. So it's still, though, they're hyperdiploid at the end of the day, I think.
Okay. So you mentioned resistance, so patients not responding to certain drugs anymore, or even kind of refractory, double, triple, we have now quadruple refractory or penta-refractory patients. The more drugs we get, the more refractory patients, of course, we get at the end. Thankfully later in time, but at some time, some patients still become refractory to all these drugs. So we also saw data yesterday where we discussed that we see in binding regions where the drugs actually bind in the cell to their effector or target protein, that we see mutations there. And also in vitro proof that a mutation confers resistance in the cell if you introduce such a genomic aberration there. Yeah. However, we also saw that many of these aberrations or these mutations that were detected are subclonal, meaning not all cells carry these. In the same patient, not all cells carry these mutations. So certainly, obviously contributing to resistance as proven in vitro, but there must be other mechanisms of resistance in the same patient, otherwise it would not explain why a patient does not respond at all to that drug. Do you have any thoughts on that?
I've been very paradoxically intrigued by it over the years because it is very clear data. Like some of these cereblon mutations, for instance, that have been observed, they clearly confer resistance in vitro. They were stable with time in some of those patients, though they never get to really huge portions of the tumor mass. One like the most obvious assumption or hypothesis that would be worth testing in those would be that the tumor cells are somehow stimulating each other. And if you can even get a subpopulation of cells that are resistant to the drug, that they can actually secrete something or provide some stimulus to the rest of the microenvironment to make those cells actually continue to be resistant.
Talking about the microenvironment, I agree that I think this is a very multifactorial process, and probably even the same patient, all different or several different mechanisms of resistance occur over time and evolve and finally lead to the refractory patients. And we also briefly touched upon very new data that I happen to present, that if you go for an unbiased approach, just similar to the newly diagnosed data set that you generated in a refractory setting, so with patients multiple times refractory to several drugs, that we see there that the genomic landscape seems to be quite different, which is not surprising given the immense pressure over years from different kind of treatment lines. And we see very interesting large-scale genomic aberrations, translocations, and so on that are typically not seen in newly diagnosed patients, as well as a lot of recurrent mutations compared to the relatively few recurrent mutations that are seen in newly diagnosed. I think for now it's not clear, of course, how exactly that confers resistance in the individual patients. So do you think that kind of from a newly diagnosed, pathophysiologically driven point of view on myeloma, that the refractory myeloma is a different kind of disease?
I think definitely especially today with the drugs we have, I think we are not necessarily creating a different disease, but by allowing these cells to have more chance to evolve with time because patients are living longer, I think we are almost seeing a different disease. Clearly in clinical action, you see a very different disease than we used to historically see. But I'm not surprised at all by genomics. And we've seen in the past that even like patients with the most genomic complexity were the ones that did the worst. So to say that what you presented, where you see really advanced patients having much more complex genomes than at baseline on average, seems to fit with that hypothesis. That so I think how that confers resistance is hard to specifically say, other than the most likely is by just having that diversity there. It's almost multi-drug resistance, right? By creating all that thing that lets it, everything we throw at it, they're now resistant at that point in time, and that's the complexity you need to have that kind of a phenotype.
Probably multi-drug resistant in a broad sense of the meaning of this word. It hits absolutely what we see in a refractory patient. Describes very complete what we see in the refractory patients. So I think in summary we had a great session there, and we learned a lot in the last very few years on newly diagnosed patients and their genomic landscape, and we are starting now to see first signs on how mechanism of resistance can evolve. Still a lot of more to learn and a lot of things to figure out, especially then whether we can adapt treatment to these kind of developments, and maybe even find new drugs to finally overcome the refractory disease in these patients. With this, we will thank you and everyone who was listening. Thank you.